Hello. Our learning objectives for today. Firstly, to develop the ability to assess stage of change and match patients to level of care. Secondly, to explore the range of behavioural treatments available for a long-term recovery plan. And finally, to prepare individualised treatment plans using multiple resources. I will provide an overview of psychosocial interventions and then focus on individual psychotherapeutic techniques such as motivational interviewing and cognitive behavioural therapy. The range and applicability of group therapies will be explored, and we'll finish with looking at mutual help groups and 12-step recovery programs. I will also incorporate examples of local providers of evidence-based treatments and references to other resources in appendices and online. We're increasingly seeing addiction as a paediatric disease, with 90% of our patients with severe addiction issues reporting problematic drug use beginning in childhood. Hence, SBIRT, or Screening, Brief Intervention and Referral to Treatment, is becoming increasingly important in the prevention of severe substance use disorders. SBIRT is delivered in a variety of settings, predominantly primary care, emergency departments, and also other settings like hospital clinics. It takes on average 4 to 5 years after someone meets the criteria for addiction for them to even seek help. So there's a lot of opportunity for screening and brief intervention during those years. Outpatient programs are widespread in the addiction care world and vary from low intensity, for example, accessing counselling on a one-to-one basis, on a weekly to monthly basis, or attending group programs which are often set up through community health centres and other addiction treatment centres. Day programs can be more intensive and follow a path of perhaps daily attendance on weekdays over a period of 6 to 12 weeks. And examples of this include the Detox program through Vancouver Detox and the STAR program, which is through a Vancouver Coastal Health South Addictions team, which is predominantly aimed at women and has a very trauma-based focus. Now, if patients are not progressing as they would like on their journey to recovery, residential treatment should next be considered. There's a huge range of support recovery facilities with different flavours to them, some perhaps more peer-based, some with more professional support. We have First Nations settings and youth-specific and gender-specific settings. Many make use of 12-step facilitation, and some do have religious foundations. Examples of these treatment facilities include Chrysalis Society, which has New Dawn Recovery House, and New Way and New Day as second stage. Turning Point has a number of houses for men, women and co-ed through the Greater Vancouver area. And the United Gospel Mission is an example of one facility in the downtown of Vancouver. Intensive treatment includes programs that deliver more formal counselling within a specific time frame, typically 6 to 12 weeks. And examples of this would be Pacifica, Maple Ridge Treatment Centre, or private facilities such as Edgewood on Vancouver Island and Homewood in Ontario. Facilities such as Heartwood and Burnaby Centre for Mental Health and Addiction are able to provide medical and nursing care in addition to addiction recovery for patients whose medical and psychiatric needs cannot be met in other settings. We have an appendix attached to this presentation of a comprehensive list of outpatient and residential treatment facilities in British Columbia. So let's take a look at the stages of treatment that a patient with moderate to severe substance use disorder will typically require. Acute care is when someone first comes into treatment. The aims of acute care are to provide a safe detoxification and stabilisation, and then primarily to engage the patient into ongoing treatment or rehabilitation. If patients complete detox only, we find that the vast majority of patients will relapse. A Dublin study showed that 92% of heroin-addicted patients without continuing care relapsed within 30 days of detox, as opposed to a 32% relapse rate after referral to continuing care. So rehabilitation is really the formal treatment process. The purpose is to help a patient maintain abstinence and to learn self-management skills, to identify and reduce threats to progress, and again to engage in ongoing continuing care. Once the first stages of treatment are done, which typically takes a couple of months, then an aftercare program is important to initiate. The purpose of aftercare is to monitor and support abstinence and encourage self-monitoring and ongoing management of threats to relapse. We like to promote participation in long-term support activities such as mutual help organisations, 12-step and ongoing counselling. We know that it takes on average 4 to 5 years of continuous abstinence for remission, for the risk of relapse and the risk of going back to drug use in the following year to drop to below 15%. So that's the baseline for the general population. So 4 to 5 years of abstinence before having a normal risk of relapse rate. So we've learnt a lot of lessons from other chronic illness models. We know that medications can help relieve symptoms and provide treatment, but we also need to recognise that behaviour change is necessary for sustained benefit. Treatment effects usually do not last long after treatment stops. So therefore some form of monitoring, support and ongoing treatment is needed. Patient retention is crucial and therefore treatment must be attractive, and we need to offer a wide range of options and alternatives to suit the individual patient's needs. So what are the available tools to affect behavioural change that we have access to? Brief interventions primarily include motivational interviewing, cognitive behavioural therapy and straight behavioural therapy. Professional counselling, either in group, predominantly now in group settings versus individual, or a combination of the two. And then we have therapeutic communities, which tend to be peer-led residential community settings without the support of professionals or healthcare providers. They take a very social view of rehabilitation and a focus on vocational rehabilitation and personal growth. And then we have the whole range of mutual health organisations, AA, NA, etc. Smart recovery. So what form should treatment take? We need to be aware that specific substance use disorders have been shown to respond better to some types of interventions. The biopsychosocial approach to addiction care recognises the role of pharmacotherapy in conjunction with psychosocial treatments. Pharmacotherapy's role in addiction treatment includes managing withdrawal symptoms, treating psychiatric symptoms and comorbidities, reducing cravings, and of course substitution therapies. So let's take a look at some of the individual substance use disorders. In general, opiate use disorders follow a medical model. We know that pharmacotherapies work very well, such as Suboxone and methadone, and ongoing monitoring, typically using urinary drug screenings and individual assessments are the basis for treatment for opioid use disorders. Psychosocial support, such as counselling, are often incorporated into opioid treatment programs. However, a Cochrane review recently suggested that adding specific psychosocial interventions did not enhance retention in treatment or opioid use. Stimulants and cannabis use disorders, on the other hand, typically respond best to behavioural treatments alone. And that's really because we haven't identified any good pharmacotherapies as useful treatments for these disorders. And then alcohol and nicotine use disorders respond best to a combination of behavioural treatments and pharmacotherapies. Many of our patients, of course, have polysubstance use disorders and thus will likely benefit from a multimodal treatment plan. Let's now look more specifically at individual psychotherapeutic techniques. In order to implement successful psychotherapy, understanding the stage of change of our patients, as described by Prochaska and Di Clementi, can be helpful. When we have determined the stage of change, We can then match our patients to appropriate types of treatment. Motivational interviewing, I've already mentioned, is a very widely used technique for helping patients achieve behavioural change. Cognitive behavioural therapy encompasses relapse prevention, as originally described by Alan Marlett, and coping skills training. And these are both evidence-based treatments. Let's look a little more closely at the stages of change. Behavioural change is a process that unfolds through these series of stages that we're going to explore right now. Pre-contemplation is the first stage. It's our patients who have no intention to change. They feel that the costs of change are perceived as worse than any benefits from reducing or stopping their drug or alcohol use. The second stage is contemplation. This is where the patients are not yet ready to change, but they're intending to take action at some time in the future. They're often very ambivalent, so there's arguments for and against changing their drug use. There are a lot of yes, but statements. Moving on to preparation. This is when the individual has decided that they would like to make a change to their drug use or alcohol use in the immediate future and are preparing for that change. This is a very vulnerable stage and needs lots of support from healthcare providers or others in their environment. Action refers to when they're in active treatment, employing specific overt lifestyle modifications. And finally, maintenance is when treatment is complete and they're working to prevent relapse. It's helpful to conceptualise this as a cycle of change, beginning with pre-contemplation and progressing through the other stages in an upward spiral. Patients may remain stuck in a stage for years and also may cycle back to previous stages. Relapse is the rule rather than the exception. Rather than seeing relapse to drug use as a failure, what we would like to do is explore with our patients the circumstances leading up to the relapse to see what could be done differently in the future. What treatments should we use? Now that we can identify and explore with our patients what stage of change they're in, what is the best technique to use for each of the individual stages? So for patients that are pre-contemplative, motivational interviewing and brief interventions are indicated. They are not ready for any more significant behavioural therapy or cognitive behavioural therapy. When our patients are contemplative, motivational interviewing techniques can help to explore their ambivalence. We can help them to explore what the benefits of change might be and decrease those costs of changing to that individual. What's important here is also exploring the sense of self-efficacy or confidence in the ability to change. In the preparation phase, when they're ready to enter action-oriented treatment, motivational interviewing is also indicated, and here we need to offer up a good menu of choices for treatment options. When they're in the preparation phase, as I said before, a very vulnerable time and lots of work needs to be done. In the action phase, this is when we incorporate our behavioural therapy and cognitive behavioural therapy modes of treatment. The majority of our patients, when we're in the primary care setting, are going to be in the first two stages of change, and it's really only those of us that work in addiction-focused settings that are going to be working more with people in the action phase. So what is our goal? Our overall goal for managing patients in the pre-contemplative and contemplative stages is to help them progress from whatever stage they're in to the next stage. Let's take a look at motivational interviewing. It's a client-centred style of interaction aimed at strengthening a person's motivation for and commitment to change. Now, it's a style of interaction, a way of talking with our patients to explore their ambivalence about their substance use and to begin making positive behavioural and psychological changes. Motivational interviewing can happen anytime, anywhere. It can be delivered in the briefest of consultations. It should always be supportive, non-judgmental and non-confrontational. The evidence for motivational interviewing is strongest for nicotine and alcohol use disorders, but is totally applicable to all other substance use disorders as well. We believe that it's most effective now when combined with other standard psychosocial treatments. So when you're delivering your cognitive behavioural therapy and your other pharmacotherapies, you can continue to use MI at all times. There are 4 foundational processes to motivational interviewing. Engagement, extremely important. That sets a whole empathic tone of understanding and collaboration. You and your patient are working as a team together. There are a number of things that you need to avoid doing during this phase. That is assessing in a judgmental way, telling the patient what you think you should do, even if you know that you do have the right answers. Being in a position of power and telling someone else what to do is not going to be very effective in evoking change. We need to avoid those power imbalances and those power struggles. We need to avoid labelling if possible. And we need to step away from being the expert. The patient is the expert in his or her own life, and we need to be very mindful to listen to everything that they're saying, because that's where answers will be found. With any visit, we need to focus on an agenda, and this really needs to be a collaborative approach again, being mindful of the patient's goals and the patient's priorities at that time. Next, we want to help our patients elicit change talk, hear what the patient's own motivations for change are. If they're able to say what they want to do, they're much more likely to have a behavioural effect or a change from that. And finally, we want to develop a plan for going forward. Plans need to be specific. We can use the acronym of SMART: specific, measurable, achievable, realistic, and within a relatively short time frame. Next, I'd like to talk about motivational interviewing and the micro skills that are very helpful in delivering MI. The acronym we use for this is OARS, and here we like to always be mindful of using open-ended questions, affirmations, which are used to reinforce the patient's desire to change, reflective statements, which is where we put into our own words what the patient has told us in order to reinforce their change talk. And finally, summarising at the end of the session, and again focusing on what their plans are for going forward. We'll look at some examples of this in the study coming up. So, some final tips for delivering psychotherapy. Even the briefest of encounters are opportunities for engaging in psychotherapy. Be mindful to engage whenever you can. Establishing a therapeutic alliance sets a whole tone of the relationship going forward. So it's very worthwhile to put in time and effort when you first meet somebody, because it's going to pay off in the long run. A therapeutic alliance accounts for at least 15% of the variance that we see in treatment outcomes in big studies. So we like to have shared tasks, goals, and emotional bonding with our patients. We know that this affects retention in treatment, affects completion of treatment, and affects overall outcomes in substance use disorders. Delivering psychotherapy is certainly very less effective when a patient is intoxicated. So if that is it's the case, usually we keep it brief and to the point. Again, still supportive and non-judgmental, and book appointment times, and hopefully might be more appropriate when they haven't been using or drinking. Some like to use individualised treatment manuals. This is really more in the realms of more formal psychotherapy, but using these pre-written treatment manuals does improve quality of research and clinical practice. An example of this would be the Motivational Enhancement Therapy manual that was developed for Project Match, which I shall just briefly talk about. Project Match was a very important study, being one of the largest psychosocial studies ever undertaken. It investigated which types of alcoholics respond best to which forms of manual-based individual counselling treatments. So they compared cognitive behavioural therapy, coping skills therapy, 12 sessions, to 12-step facilitation therapy of 12 sessions and motivational enhancement therapy of 4 sessions. What was found was that all groups showed improvement with no consistent differences between any of the treatment groups. Efficacy did not appear to be enhanced by matching clients to different treatments. So when they tried to sort patients into different kind of personality styles or different motivations for treatment, it didn't matter which group they went into, there was no difference in outcomes. The strongest predictors of long-term drinking outcomes were the readiness to change in the client and the perception of self-efficacy. So in motivational interviewing parlance, this readiness to change equates to motivation, and self-efficacy equates to confidence to change. So let's take a look at our first patient. He is a 30-year-old married man who is indulging in high-risk drinking. He reports that he has 3 to 4 beers after work on a regular basis and 8 to 10 beers on Friday nights and on weekends. He reports that occasionally he suffers from blackouts on the weekends. He has poor sleep, hangovers, and increasingly missed days at work. However, he tells you quite clearly he's not interested in quitting drinking. So our key treatment questions are: what stage of change is this patient in? And what techniques could we use to motivate this patient for change? So I'm sure you can identify that he is pre-contemplative. We could start in this interview with this patient by saying, wow, you're drinking way too much. You should really consider quitting. But if we were to say that, he would probably respond with justifying his use. Well, you know, I have a really busy job. I'm really stressed. I need to relax. It's really helpful for me to relax at night. All my friends drink the same amount as I do and they're all fine, etc. So rather than taking that approach, we could use a motivational interviewing style, remembering our open-ended questions and assessments, reflective statements and summarisations. So firstly, we would look to engage him. You've mentioned that you drink every day. Would you like to talk about this? If he's agreeable, then we can explore his ambivalence around his drinking. So we always start with asking about the positive effects of alcohol or drug use before going on to the negative effects. What do you like about drinking? And that gives him an opportunity, and you can then affirm that you hear what he's saying and that you're non-judgmental about that. Then you can move on to ask, so how about the negatives of drinking? And he will likely come up with some of the things that he's already told you. Well, I don't like those hangovers. I don't like that I'm missing more work. Starting to argue with the wife, etc. So then you can reflect back in your own words of those things that he's told you. You're worried that it might be impacting on your work, and you feel that your health might be suffering. The next step would then be to elicit some change talk. So an example would be, what would you like to change about your drinking, if anything? And if you did decide to cut back, how would you do it? So, you know, people have been using drugs and drinking for a long time. They know what works for them and what doesn't. So if we can get him to say what works for him, then we could give some positive reinforcement around that. There are 2 parts of motivation: the importance of making a change and then having the confidence to change. So sometimes in MI, we would ask questions, what would it take to make you more confident to follow through on cutting back? Or what would it take to make it more important for you to stop using or drinking? And sometimes we rate this on a scale of 0 to 10, and then we can talk about, if they give you a number, say, well, it's not that important, I'd say it's about a 3 out of 10, then you can explore what would bring it up to a 5 or a 6. We then summarise again the salient points that we've heard come through, what we've heard in his change talk, and then finally we need to wrap up and make a plan. Where do you want to go from here? He might tell you, well, I think I'd really like to not have any more blackouts. That's good. You've got a single thing to work towards. So that at that point, you could bring out your Canadian low-risk drinking guidelines and present that to him for him to take away and look at, and explore with him ways of reducing his drinking to safe levels. You would then want to be proactive in booking a follow-up appointment and continue regular brief interventions along these lines using these techniques. At follow-up appointments, you would want to monitor any behavioural change, explore with your patient what worked and what didn't, and explore his motivation and confidence to change again. Let us now move on to exploring group therapies. We will look at the goals of the immediate goals and the longer term goals of group therapies, the roles that they play and the niche that they occupy in the continuum of addiction care, and the types of group treatments that may be available to our patients. So the immediate goals of group therapy are to help reduce substance use, to improve the individual's ability to function, and to minimise any medical and psychosocial complications of the drug or alcohol use. As we've said before though, behaviour change for lasting benefit is a long-term goal. So through group therapy, we can teach and improve coping skills, we can help facilitate self-efficacy, we can improve social supports and reward positive behaviours. What specific attributes does group therapy have over individual settings where individual therapy is delivered? Well, groups make use of the need to belong and the healing power of human connections. They help to reduce feelings of isolation and shame, which are so prevalent in people with substance use disorders. They allow patients to help themselves by helping others. And this is one of the underlying tenets of the therapeutic communities that we mentioned before. Groups will provide emotional support, information and understanding in a cost-effective setting. I would now like to run through the different types of group therapy. Milieu groups. These typically are offered in residential programs. They have a very behavioural focus, so check-in in the mornings, scheduling for the day, setting goals for the day or the week, and identifying risks that may be coming up in the immediate future. So not much of the cognitive part of behavioural therapy, but a real behavioural focus. They enhance bonding, reduce stigma, and provide encouragement and feedback. Psychoeducational groups tend to be more focused on specific topics related to addiction and recovery, and span a whole range of things, including very medical topics, psychiatric things, how various substances of abuse and alcohol can affect the body and the brain. Cognitive behavioural therapy is a more formal way of teaching coping skills, encouraging ongoing abstinence, supporting the client in reducing or stopping their drug use, and then relapse prevention once the patient is in the action-orientated phase and the maintenance phase of recovery. Mindfulness-based relapse prevention is a relatively new and popular and is evolving more evidence for its efficacy. It is a blend of cognitive behavioural therapy, including relapse prevention, and mindfulness, first brought to the Western world, I guess, by John Kabat-Zinn. Recent studies, particularly looking at the use of mindfulness-based relapse prevention in stimulant users, has been shown to reduce the negative affect associated with being in recovery after stimulant use and helps manage stress reactivity. Contingency management is a systematic delivery of positive reinforcement for desired behaviours, and again has a strong evidence base for being successful in the short term at least. So drug and alcohol use can be managed basically by using operant reinforcement procedures. So for example, vouchers or prizes are given as a reward for the desired behaviour, which is monitored typically by urine testing for stimulant use. Incentives are removed when the target behaviour does not occur. And frequent monitoring is required for this to be successful, and immediate reinforcement of the positive behaviours, in this case the negative urines. As I said, particularly useful for stimulant users. It does require frequent contact with a patient and needs to be delivered well, it can be delivered in an outpatient setting, but has been used more and more in inpatient treatment facilities in British Columbia. Let's take a look at our second case study for the day. Your patient is a 42-year-old female with a severe cocaine use disorder for many years. She has comorbid bipolar disorder and a past history of childhood sexual assault. She has 3 children, all in foster care, and has recently extracted herself from a domestic violence situation and is now homeless, staying at a friend's place. She's requesting treatment. She feels like she is totally done with this life and she wants to get her children back. Our key treatment questions are: what treatment setting will best address the needs of this patient? And what skills does she need to acquire to enable behavioural change? So hopefully you can identify that this patient is in the preparation phase. She is actively looking for treatment and preparing herself for abstinence and treatment. The best setting for her, given that she is homeless and has a severe substance use disorder, would be a residential treatment setting. If she is psychiatrically stable, then support recovery with milieu therapy would be a good place to start. If, however, her bipolar disorder is not well controlled, she may be a better fit for intensive residential treatment program where she can access nursing and more formal medical care to help address her concurrent psychiatric disorder. In the interim of waiting to get in somewhere, you could refer her to your local counselling services to help prepare her for treatment. Application forms would need to be done to get into most of these places, and we can use motivational interviewing techniques to maintain the engagement and strengthen her commitment to follow through with treatment. She may also like to go to a detoxification facility whilst awaiting to get into treatment. What skills does she need to acquire? Let's assume that she is now in a treatment setting and getting her bipolar needs attended to, and she's in the stage of change of action. In early recovery, we focus on very behavioural concepts of CBT. So focusing on safety, focusing on routine, and managing emotions and mood. Early relapse prevention includes avoiding any high-risk situations and perhaps attending meetings on a regular basis. Following early recovery, we can start introducing more psychoeducational groups such as mental health, particularly for this woman, and medication management. More formal cognitive behavioural therapy could be employed, and in particular working on recognising triggers for relapse to drug use. So these triggers can be internal, so feelings of anxiety and depression, or especially for people that have bipolar disorder, feeling really good and powerful and able to manage anything. So bipolar disorder is one of those things where there is a heightened risk of relapse due to mood instability. There are also external triggers that people need to figure out what's triggering for them. So that's environments, other people, friends that use, etc. Analysing the chain of events that lead to a slip or a relapse is a core component of cognitive behavioural therapy. And teaching cognitive skills to manage cravings such as thought stopping, the red stop sign, urge surfing, which refers to getting cravings or urges to use can be seen as a wave, and that you just need to ride the wave and that there is an end in sight, you know, in the near future, and just getting through that difficult time. And perhaps employing delaying decisions before you go out and use. The Seeking Safety program I want to mention, importantly, as it is very widely employed here and elsewhere in North America and the world. It is an evidence-based, present-focused counselling model that's widely used in many settings to help people attain safety from trauma and substance use. So it directly addresses both trauma and addiction without requiring patients to delve into a full trauma narrative. So first stage trauma treatment, if you like. Finally, with our patient, once she moves into the maintenance phase of change, which typically would be 3 to 6 months at least after entering recovery, the options for her would include stepping down to a second stage support recovery environment, such as New Way or New Day through Chrysalis Society. Here, clients live with other clients in a abstinence-based setting where they experience increased autonomy and are able to focus more on things like vocational rehabilitation, ongoing social rehabilitation. They can start accessing outpatient services, and for someone in this situation with a particular focus on ongoing mental health counselling and perhaps going forward some more formal trauma counselling. Alternatively, she could go into independent housing, and there are certainly some programs in some places which support addiction recovery. And throughout all of this, we should be mindful of referring to other community-based support groups, such as AA or NA. So that is a nice segue into our final topic for today, which is looking at 12-step programs. 12-step mutual help organisations are very widespread, Alcoholics Anonymous being the most common. AA is an international organisation of recovering alcoholics that offers emotional support through self-help groups and a model of abstinence for people recovering from alcohol dependence, typically using a 12-step approach. We'll take a look at the effectiveness of such programs and a little more about 12-step facilitation and what that means. So what's the rationale behind 12-step mutual help organisations? Well, millions of people attend worldwide and many continue very long term. It's widely available, it's inexpensive, in fact it's free for everybody with voluntary donations only. Clients can attend as intensively and as long as desired. It's able to provide access at high risk times, high risk for relapse, when professional services are not typically available, for example on weekends, night times, holidays. There are always resources available and meetings to attend. Entry-level threshold, everybody is welcome, and one of the basic tenets is that it is anonymous. Group time helps with constructive use of time that was formerly occupied by drug use. One of the biggest predictors of relapse is if someone is bored and doesn't have other things to fill their time. It helps to establish new social networks that provide a lower risk environment for relapse. There are disadvantages to these programs, foremost of which is there is no quality control over the individual groups as they're peer-led. The core concepts of 12-step groups are abstinence from all drugs of abuse. Having said that, you do not need to be sober to attend. Acceptance, accepting powerlessness over drug or alcohol use, and working through denial, which is so prevalent in the settings of substance use disorders. There is certainly a spiritual component to it with the thoughts of surrendering to a higher power, and pragmatism, which is actively working the program and actively working the steps, reading the big book. There's a very wide variety of mutual help groups, and we'll have an attachment to this lecture, which is more fulsome than what I have here, but this is just a small snapshot of what's available. AA being the most prevalent, but also Narcotics Anonymous, Cocaine Anonymous, dual recovery, and lots of things in between. Smart recovery is an alternative for those that are not interested in the higher power philosophy and is not a 12-step based. Smart recovery stands for self-management and recovery training. And there are lots of smart recovery groups around in the bigger cities for sure, and you can access this by looking online. How effective is 12-step? Well, observational studies certainly support mutual help organisations as standalone or adjuncts to other treatment. There's been 4 meta-analytic reviews done over the years, the most recent of which was a Cochrane review in 2009. And looking at them all together, you can surmise that AA confers a consistent, moderate, beneficial effect on par with other professional interventions. Certainly that was borne out in the Project Match study that we looked at previously, which certainly showed that all groups, that 12-step facilitation did just as well as CBT and motivational enhancement therapy. Some further data from Project Match, however, does show that higher abstinence rates were seen in the 12-step facilitation arm at 1 year, where patients were twice as likely to be sober and a third as likely to be sober again at 3-year follow-up. Again, through Project Match, we were unable to identify which patients were best suited to a 12-step facilitation approach. Having said that, experimental studies overall have failed to demonstrate any superiority of 12-step and AA programs over other interventions. And we should say that it has been noted that coercing people to go to 12-step can be harmful and hence is not recommended. I think that is the case for many other types of treatment, psychosocial treatments as well. So what is 12-step facilitation? Well, it can refer to two things. It's an informal support and facilitation for regular involvement in organised peer support, or it also refers to that structured, manual-driven process that was developed for Project Match. We know that clinical referral strategies can enhance participation and outcomes in drinking behaviours anyway. So clinically introducing, referring and linking patients to AA or NA during addiction treatment can enhance outcomes, particularly continuous abstinence, and can reduce healthcare costs. So the standard referral would be giving your patient a list of locations of meetings and suggesting that they attend. But if we want to really facilitate attendance at these things, we need to be more intensive. We need an introduction to 12-step philosophy, perhaps with more formal written material. We can help our patients meet with an AA member. You can make a phone call from your office. You can give that information to your patient to meet up with an AA member. They can help facilitate attendance at that first meeting, which can be really difficult. And then once you've set this in motion and have an agreement perhaps to attend 3 meetings in the next week, then follow up with that and see how that goes and get feedback as to whether the client was able to manage that or what the barriers were to attending meetings. So what are the overall recommendations for clinical practice regarding 12-step and AA? So you want to tailor your AA discussions to the patient's history. So if someone's been involved in AA or NA before, they will very likely benefit from re-referral and support in going again. Successful affiliation with AA has been associated with male gender, with men that have more severe alcohol use disorders and that show a greater commitment to abstinence and are fairly well supported socially. Interestingly, those that do get less support from their intimate relationships do better at AA. And those that have a greater desire to find meaning in life, obviously AA can support that and facilitate that. Patients without an AA history may respond more positively to a more motivational enhancement approach and other treatment modalities. However, you should always consider AA referral even in patients that are low in religiosity, because even though they are less likely to attend in the first place, once they start going, they are just as likely to benefit. Once they engage in AA treatment, they are just as likely to benefit as others. And finally, recommend addressing barriers to attending. So this is in your follow-up and working with your client. So what are the potential barriers to AA attendance? I don't believe in God. How would you respond to that? Many people don't believe in God that go to AA, and it is not a big part of the overall scene of AA, and particularly with different groups. I don't like to talk in a group, so there's no requirement to talk in an AA meeting. If for some reason someone is asked to talk, you can just say pass. I don't have a way to get there. Well, obviously, volunteers from AA are very happy to help with transport and supporting newcomers by calling AA. I don't want anyone to know about my drinking. So anonymity is important in AA. There are closed groups and open groups. And so for those that are particularly concerned about that, attending closed groups would be preferable. I can't stay sober. So the only requirement for attending an AA meeting is the desire to stop drinking. I don't like my group. I went to AA, no, they were a bunch of rednecks or whatever. There are many alternative groups, so encourage trying others. Let's take a look at our final case study for today. So your patient is a 32-year-old single mum. She has had alcohol use disorder for the past 10 years and she suffered with postpartum depression following the birth of her daughter. She has recently completed a 3-month residential treatment program and has now progressed to supported addiction housing and is parenting her 3-year-old daughter with the support of her mother who lives nearby. Our key treatment question is, how can this patient maximise her chances of ongoing sobriety? So, working the steps and linking to AA begins in support recovery. So this patient has already been attending 5 to 6 meetings a week for the past 3 months. She's well engaged and she's been exposed to a variety of groups and has selected one as her home group. What we would like to do is encourage relationship with a sponsor, and this has likely already happened with her, that she has a sponsor that she feels comfortable with. The sponsor acts as a guide to the 12 steps and as a role mentor to the patient. They're available usually at all times for support, particularly during times of relapse risk. So a patient will always carry their sponsor's number and call up if feeling wobbly for any reason. We would like to encourage regular group attendance, and it's been shown that in these early action phases and early maintenance phase that it's preferable to go at least 3 times a week to AA or NA meetings. It's good to be affiliated with a home group, but also to explore other varieties, for instance women's only groups where there's going to be a focus on more family based things and childcare and stuff. And we also need to look at other psychosocial supports for this young woman. So particularly childcare and parenting groups. Sometimes if someone's been in addiction for a long period of time, you know, there's a lot of room to move with learning parenting skills. We should also encourage ongoing check-in with an addiction counsellor and an addiction team preferably. So, thank you, and I hope you are now feeling well prepared and confident to support your patients on their journeys to recovery.